Hello, everyone, and welcome. My name is Gary Parker. I'm the Associate Dean for External Affairs at the Brown School at Washington University in St. Louis, where I also have the great privilege of directing the Clark Fox Policy Institute. And welcome to Open Classroom. It's an initiative that we started right about the time that the pandemic kicked off as a way of kind of opening the virtual doors of the Brown School and allowing those not just from the St. Louis area, but far beyond to come and join us, hear from some of our faculty, get up-to-date information about what's happening, not only within the Brown School, but some of the research that's going on, particularly focused on COVID-19. And it's been just a really wonderful experience, thanks to all of you who have continued to join us week after week. I want to tell you about a really interesting program that we have coming up on Thursday. It's right at noon. It's what we call the Brown School Convocation and Distinguished Faculty Award presentation. This is something that we usually just did internally, but we want really to invite all of you to be a part of this. At the beginning of each academic year, we feature one of our distinguished faculty, and they give a convocation speech, which is kind of like kicking off our new academic year. This year, we'll be hearing from Deborah Hare-Jashu, who is the Joy Wood Professor, and she's going to be giving a talk called Reducing Chronic Disease Disparities in Women's Health, Moving Science to Real-World Impact. I'll put a link in the chat feature where you can register for that event, and you'll receive the Zoom information on the morning of, just like you would for this. And of course, I have to thank my co-host, Janet Gillow, the Director of Professional Development here at the Brown School. Always happy to do these events with you, Janet, and always great to spend this time with you.
Thanks, Gary. Likewise. Welcome back to Open Classroom, everybody. After about a 2-week hiatus, as Gary mentioned, we are ready to kick off the academic year. We're adding offerings all the time. So if you haven't been on the website recently, I do encourage you that every day there's something new up there. And today's program is a wonderful way to launch our semester. I do want to let you know that your camera and your audio are muted throughout this, so we can't see you or hear you, but we definitely want you to be a part of this conversation. The chat feature is enabled, and that's how you can send in a question or comment. And then as the lecture draws to a close, Gary and I will field those for Dr. An for you. But now it's my great privilege to introduce today's speaker. Dr. Ruopeng An is an assistant professor at the Brown School. He conducts research to assess environmental influences and population-level interventions on weight-related behaviors and outcomes throughout the life course. In particular, his work assesses socioeconomic determinants and policies that impact individuals' dietary behavior, their physical activity, and sedentary lifestyles. His work includes focus on children, adults of all ages, and people living with disability. The goal of this research is to develop a well-rounded knowledge base and policy recommendations that can inform decision-making and the allocation of resources to combat obesity. So here to present new findings, very timely, please welcome my friend and colleague presenting Projecting the Impact of COVID-19 Pandemic on Childhood Obesity in the U.S. Microsimulation Model. Welcome, Dr. Ruopeng.
Thank you so much, Janet and Gary. I really appreciate your assistance. And welcome, everyone. Good afternoon. My name is Ruopeng An, and today we'd like to talk about a new research we've recently completed and published. The title is Projecting the Impact of COVID-19 Pandemic on Childhood Obesity in the US, a Microsimulation Model. If you have some questions, feel free to use the chat box, and we will try to go over all your questions by the end of the presentation. So first, let's talk about the time frame of the study. The study was conducted in April 2020, a few months ago, when the COVID-19 pandemic swept the US, leaving nationwide shutdown and school closures. And at the same time, the primary public health concern was COVID-19 spread and infection, whereas a variety of other physical and mental, we call collateral damages caused by the pandemic and the policy countermeasures were much less understood at that time. So what you might expect to get from this talk, first, we would like to spend some time to go over the potential interrelationship between COVID-19 and physical activity and childhood obesity. And we'll also go a little bit talking about the microsimulation model and its application on policy evaluation. And finally, we'll talk about the potential policy countermeasures to mitigate the negative impact of COVID-19 on childhood obesity. First, let's talk about physical activity under COVID-19. The COVID-19 pandemic has been reported in over 200 countries, claiming massive illnesses, hospitalizations, and death tolls. Following the declaration of a national emergency in the US in response to the disease, 42 states and Washington, D.C. issued stay-at-home orders from March 19th to April 7th. Here, I would like to add one issue regarding that Dr. Shenyang Guo and myself and a few other colleagues were conducting a study looking at the impact of COVID-19 shutdown and stay-at-home orders on mortality. So we'll present the findings in later sessions in the open classroom. So those orders covered about 95% of the US population, and closely related to the stay-at-home orders are various non-pharmaceutical interventions that aim to promote social distancing. One of the most widely adopted policy interventions across the states is school closures. The US Centers for Disease Control and Prevention, the CDC, recommended school closures in response to community transmission of COVID-19. And all 50 states plus the Washington, D.C. have issued executive orders on school closures, and most states issued these orders during March 13th to 23rd. It is likely for the school closure in many places in the US to continue for the rest of the calendar year. When we were conducting this research in March, it was unclear to what extent the school closures are going to continue. But just at the status quo, it is possible that in many places in the US, the school closure may continue for the rest of the calendar year, if not extending to 2021. It remains unclear whether and on what scale schools would reopen, because such decisions by the states are primarily contingent upon how the COVID-19 pandemic evolves in the fall and winter. The COVID-19 pandemic may expose children to an elevated risk of childhood obesity. We all know that the childhood obesity in the US is already pretty severe. So in the US, childhood obesity prevalence increased by more than threefold over the past few decades. In 2007, 2008, the most recent data shows that approximately 18.5% or 13.7 million children in the US aged 2 to 19 years old had obesity. And we also know there is a significant racial ethnic disparity in childhood obesity. Non-Hispanic Blacks and Hispanics have higher childhood obesity prevalence than non-Hispanic whites and Asians. Physical inactivity among children is one of the major behavioral risk factors for childhood obesity. Therefore, the physical activity guidelines for Americans, we are referring to the most recent 2018 version of the guideline, recommend 60 minutes or more of moderate to vigorous intensity physical activity daily among children. That's about 1 hour of physical activity daily. On the other hand, over 3/4 of children in the US did not meet the guidelines recommended daily physical activity level based on a recent CDC report. Physical education is a mandated part of the school curricula in most states. And we all know that PE contributes to children's daily accumulation of physical activity and is of particular importance for those who have obesity or lack access to physical activity opportunities in their home environment. And considering that most of the schools closed nationwide, children in the US have missed the opportunity to participate in regular physical education classes and other school-based physical activities. For example, recess, after-school sports programs, etc. At the same time, children are also less likely to make up for their lack of physical activity due to the COVID-19 and the stay-at-home orders, because a lot of parks and outdoor recreation areas across the states are closed that limit physical activity opportunities outside. Now, after a few months, starting from April, when we did the research, we see a gradual reopen of the parks and recreation facilities, but still, for a majority of those places, they have only open to a limited scale and capacity. So in sum, the COVID-19 pandemic has reinforced the obesogenic environment conducive to physical inactivity and sedentary behavior. And children living in such a condition are likely to be exposed to an elevated risk for energy imbalance and unhealthy weight gain. So the goal of the study is that given the looming influence of COVID-19 on physical activity and the deep uncertainties about how the pandemic may evolve in the future, it becomes critical to assess the impact of COVID-19 on childhood obesity and project its trajectory in response to the pandemic. We argue that such information we learned from our research will be valuable to policymakers at federal, state, and local levels, as well as various stakeholders, for example, school principals, district leaders, community agencies, and families in designing and implementing countermeasures to minimize the detrimental impact of COVID-19 on physical activity and prevent children from obesity onset. In sum, the COVID-19 pandemic in the US led to nationwide stay-at-home orders and school closures, and declines in energy expenditure resulting from canceled PE classes and other reduced opportunities for students to engage in regular physical activity at school may elevate childhood obesity risk. Therefore, this study aims to estimate the overall impact of COVID-19 on child obesity, mainly through two channels. One is through the school closure, and the other is through restrictive opportunities for people to engage in regular physical activity in the summer. So let's talk about the study sample. The study sample of this microsimulation model was retrieved from the early childhood longitudinal study, kindergarten class of 2010 to 2011, or the ECLSK 2011. The ECLSK 2011 is a longitudinal study sponsored by the US Department of Education. It is a very unique data set that provides thousands of variables of interest to researchers and policymakers. But the shortcoming of this data is that not a lot of health information is collected from the enrolled students because it's sponsored by the Department of Education. So most of the outcomes pertaining to academic outcomes rather than health outcomes. The same children were followed from the kindergarten all the way through the 5th grade. So it is a longitudinal panel study. And most children were aged 5 to 6 years old when they first entered the study. And information were collected in the fall and the spring of the kindergarten. And again, in the fall and the spring of the 1st grade, fall and spring of the 2nd grade, spring of the 3rd grade, spring of the 4th grade, and the spring of the 5th grade. So there are a total of 9 waves of data available in the data set. And children in the ECLSK 2011 comprise a nationally representative sample drawn from both public and private schools attending both full-day and part-day kindergarten in 2010 and 2011. A total of over 15,000 children with diverse socioeconomic and racial ethnic backgrounds participated in the ECLSK 2011 and were followed up to 9 waves from kindergarten through 5th grade. And now let's spend a little bit of time talking about the microsimulation model, which might be an alien term to some of you. So we use a microsimulation model to project the impact of COVID-19 on BMI-Z scores, we call BMI-Z, and childhood obesity. And microsimulation is a system science approach that examines behaviors and outcomes resulting from interactions among multiple system components over time. The microsimulation model originated in applications to problems in the physical sciences, and it has been increasingly applied nowadays to other areas, primarily due to its capacity to integrate large amounts of data from diverse sources and also model complex interactions among determinants of policy outcomes at different levels. Here we give you a few examples. It can model the macro determinants, for example, the demographic, social, political, or economic trends. And it can model institutional determinants, government regulations or programs. It can also model local determinants, for example, neighborhood physical environment, beauty environment, and food environment. And at the same time, it can model individual determinants, for example, personal characteristics, personal choices, references, or actions. So I apologize, I won't be able to answer your questions in the chat, but I believe Janet and Gary, my dear colleagues, are monitoring the chats, and they will be able to summarize your questions, and we will answer your questions by the end of the presentation. We really appreciate your patience. And the microsimulation model used the data from ECLSK 2011 kindergarten cohort that was first interviewed in 2010-2011 to simulate changes in BMI-Z, the BMI-Z score, and childhood obesity prevalence from April 2020 to March 2021. Just to remind you that this study was conducted in April 2000. So at that time, we were trying to predict the childhood obesity trend all the way to March 2021. The study samples trajectory of BMI z-scores and childhood obesity prevalence was compared between the control scenario. The control scenario is the scenario without the COVID-19 pandemic. So everything is normal. And the 4 alternative scenarios with the COVID-19. And now let's talk about what are those 4 alternative scenarios with COVID-19. So scenario 1 assumes a 2-month nationwide school closure due to COVID-19 only in April and May 2020. That was because the study was conducted in April. I would say probably the best, the most desirable scenario is that the pandemic was over by May 2020. But of course, it is not the case. And scenario 2 assumes scenario 1 and then to be followed by a 10% reduction in daily physical activity in summer from June to August. So this reduction by about 10% in daily physical activity was really resulting from the limited use of parks and other exercise facilities, and most people stay at home. And then scenario 3 assumes scenario 2 to be again followed by a 2-month school closure in September and October. So if this the pandemic continues and students still cannot go to school in September and October, what would happen? So that is the scenario 3, what scenario 3 try to estimate. And scenario 4 is the worst case in all the scenarios. I won't say it's the worst case of all because we're still not sure what would happen following the end of this calendar year. But anyway, scenario 4 assume scenario 3 to be followed by an additional 2-month school closure in November and December 2020. So basically, scenario 4 assumes that the pandemic goes on and the school closure is not improved till the end of this year. So for each of the 4 alternative scenarios, a full resumption of routine life and social operations immediately following the event and until the end of the study period, which is March 2021, is assumed. So that is one assumption of the model. And under the 4 alternative scenarios, the COVID-19 pandemic is expected to positively impact kindergartners' body weight, and of course, consequently, the BMI z-score and childhood obesity prevalence through reduced energy expenditure resulting from canceled PE classes during the academic month, and also the reduced physical activity during the summer break. In the ECL, now let's move on to talk about the anthropometric measures in the ECLSK. So in the ECLSK 2011, children's height and weight were measured during each wave of data collection. A short board, basically a tall wooden stand with a ruled edge used for measuring height, and also a digital scale were used to obtain those objective measurements. And trained assessors recorded children's height in inches to the nearest 1/4 inch and body weight in pounds to the nearest 1/2 pound on a standardized recording form, and then entered the measurements into a laptop computer. Children were asked to remove their shoes before the measurement, and each measurement was taken and recorded twice to ensure reliability. During the 6-year study period of the ECLSK 2011, children's height and weight were measured in a total of 9 waves. once per academic semester from kindergarten to the 2nd grade, and once per academic year from the 3rd to 5th grade. And we use restricted cubic spine regressions were performed to interpolate each child's height and weight by month. So you might not be familiar with this type of regressions, but basically what we did is try to estimate the child's height and weight by each month, since most of the height and weight were not available by month, but available only twice or once a year. Childhood obesity is defined as BMI z-scores greater than or equal to the 95th percentile based on the CDC sex and age specific growth chart. And how we measure energy expenditure. In comparison to the control scenario without the COVID-19 pandemic, the reduction in energy expenditure in the 4 alternative scenarios with the COVID-19 is assumed to result from 2 independent sources. One is the canceled PE classes during the academic month, and the other is the decreased physical activity during the summer break, that is from June to August. And we follow Ken and Mackenzie's paper and use their equations to calculate energy expenditure resulting from PE class participation. Just for the time's sake, we won't go in detail into the equation. And due to nationwide stay-at-home restrictions and closures of exercise facilities, for example, the YMCA, the gyms, recreation centers, kindergarteners' physical activity is likely to be adversely affected during the 2020 summer break. At that time, when the study was conducted, it was a hypothesis, but now coming through the summer, we know that partially it was true that students' physical activities are impacted indeed by the closure. So the microsimulation model assumed a 10% reduction in daily physical activity among US kindergarteners. So we use this equation 2 from the other paper. We apologize that we didn't add the reference to calculate the energy expenditure resulting from reduced physical activity during the summer break. You may have some questions regarding why we assume a 10% reduction, why not higher or lower? We'll go over that question in a minute. And now let's first talk about the model assumptions. There are 3 major model assumptions, as we know that all models are wrong, but some are useful. So we need to make some assumptions to make the model work and simplify the reality. So the first assumption is children's reduction in physical activity during the academic month is entirely attributable to the cancellation of PE classes. And we know in reality this is not true because schools provide many other physical activity opportunities besides the PE classes, such as recess, walk or bike to school programs, and after school sports programs. So in such a case, the microsimulation model would provide a conservative, mean a lower bound of the estimate for the true impact of COVID-19 on physical activity reduction and childhood obesity. And the second assumption is children's energy imbalance or surplus is influenced by reduced physical activity only. And we also know that in reality, many other factors under the COVID-19 pandemic may impact children's physical energy expenditure. For example, a change in diet, school meals versus family meals, the students' sleeping patterns, and stress or anxiety levels. And the third, we assume a 10% reduction in physical activity during the summer break. And that assumption was based on a study of adult Fitbit users in the US. On that study, they estimate the global reduction in physical activity measured by Fitbit use, and they found a 12% reduction in physical activity due to the COVID-19. So we adopt a 10% reduction based on that study. And in the sensitivity analysis, an 8% and 12% reduction in physical activity during the summer break were used to assess their respective influence on model estimates. And now let's move on to talk about the modeling results. So as we can see, this figure shows the simulated kernel density distribution. Basically, is a statistical distribution of the BMI-Z scores in March 2021 under the control scenario and the 4 alternative scenarios. That remind you that the control scenario is without COVID-19, and the 4 alternative scenarios were with increasing length of the COVID-19 impact from 2 months, 4 months, 6 months, to all the way to the end of the calendar year of 2020. So in comparison to the BMI distribution under the control scenario without the COVID-19. So that is denoted by this line, the darkest line here, that is the control scenario. Model estimates under the 4 alternative scenarios gradually shifted from the left all the way to the right with higher peaks, reflecting a monotonic growth in the mean BMI-Z scores when the duration of the COVID-19 increased from April to May all the way to November, December in 2020. And this figure, the figure 2, shows the simulated change in BMI-Z scores from April 2020 to March 2021 under the control and the 4 alternative scenarios, as denoted by the legends here. So in the absence of the COVID-19 pandemic, the mean BMI-Z score among US kindergarteners gradually increased from 0.497. Sorry, hold a second. My son is interrupting my talk. So, 如果你得找一个其他的地方去，现在不行，你要找一个其他的地方再重新上一次。So I apologize for the interruption. My son and I are sharing the same office. So the figure 2 shows the simulated change in BMI-Z score from April 2020 to March 2021 and the control and the 4 alternative scenarios. In the absence of the COVID-19 pandemic, the mean BMI-Z score among US kindergarteners gradually increased from 0.497 in April 2020 to 0.530 in September 2020 here, and subsequently declined to 0.487 in March 2021. In contrast, under scenario 2, scenario 1, 2, 3, and 4, the mean BMI-Z score started at 0.531 in April 2020, further increased to a value of 0.591 in September, 0.623 in August, 0.679 in October, and 0.718 in December, and then gradually declined to 0.543, 0.572, 0.629, and 0.685 in March 2021, respectively. And figure 3, this figure shows the simulated change in childhood obesity prevalence from April 2020 to March 2021 and the control and 4 alternative scenarios. In the absence of COVID-19, obesity prevalence among US kindergarteners gradually increased from about 13.5% in April 2020 to 14.77% in March 2021. In contrast, under scenarios 1, 2, 3, and 4, with the COVID-19, despite some modest periodical fluctuations, the childhood obesity prevalence in large observed a steady increase from 13.86 in April 2020 to about 15.4% in scenario 1, 15.7% in scenario 2, 16.45% in scenario 3, and 17.2% in scenario 2 by the end of the study period in March 2021. And this figure reports the simulated increase in BMI between the control scenario and the 4 alternative scenarios in March 2021 by sex. The estimated impact of COVID-19 on BMI-Z was modestly larger among boys than among girls. For example, compared to the control without the COVID-19 pandemic, scenario 4 was associated with an increase in BMI-Z score by about 0.209 among boys and about 0.187 among girls. And the difference is statistically significant. And this figure shows the simulated difference in childhood obesity prevalence between the control scenario and the 4 alternative scenarios in March 2021 by sex. The estimated impact of COVID-19 on childhood obesity prevalence was modestly larger among boys than girls. For example, compared to the control scenario without the COVID-19, scenario 4 was associated with an increase in childhood obesity prevalence by about 2.7 percentage points among boys and about 2.013 percentage points among girls, respectively. And finally, this figure shows the simulated increase in childhood obesity prevalence between the control and the 4 alternative scenarios by race and ethnicity. Here we break down the simulated students into non-Hispanic whites, non-Hispanic blacks, non-Hispanic Asian, non-Hispanic other race, and Hispanic Latinos. We find that in general, the estimated impact of COVID-19 on child obesity prevalence tended to be larger among non-Hispanic blacks and Hispanics, whereas smaller among non-Hispanic whites and Asians. For example, compared to the control scenario without the COVID-19, scenario 4, if you can look at the last panel here, in the scenario 4, it is associated with an increase in childhood obesity prevalence by 3.13 percentage points among non-Hispanic blacks here, and about 2.89 percentage points increase among Hispanics here, and 1.988 percentage points among non-Hispanic whites, and about 1.948 percentage points among non-Hispanic Asians, respectively. We know that there are a lot of results to absorb, so we summarize the key points here. So the summary of results relative to the control scenario without the COVID-19, we find that scenarios 1, 2, 3, and 4 with COVID-19 were associated with an increase in the mean BMI-Z score by 0.056, 0.084, 0.141, and 0.198 units, and an increase in childhood obesity prevalence by 0.64, 0.97, 1.67, and 2.37 percentage points, respectively. And also, we find some population heterogeneities in the impact of COVID-19. Compared to girls and non-Hispanic whites and Asians, the impact of COVID-19 on childhood obesity was modestly larger among boys and non-Hispanic Blacks and Hispanics, respectively. And how do we interpret the results? The model predicts that even under the very best scenarios with only 2 months of school closure alone, that could result in an increase in the childhood obesity rate by 0.64 percentage points in the US. And in the worst scenario we simulated, scenario 4, if school closures continue to the end of 2020 due to unsubdued community transmission of COVID-19, the childhood obesity rate in the US might further increase by 2.37 percentage points. If we translate the percentage into numbers nationwide, if such impact is universal among all US children aged 5 to 17 years, by March 2021, approximately 1.27 million new childhood obesity cases will develop under the COVID-19 pandemic than otherwise without the pandemic. We also find that the estimated sex differences in the impact of COVID-19 on childhood obesity is mainly because of the differential energy expenditure reduction between boys and girls. So there is a sex difference in the impact of COVID-19 as we estimated, but the difference is relatively modest. And the primary contributing factor to the estimated racial ethnic differences in the impact of COVID-19 on childhood obesity pertains to the differential baseline BMI-Z distribution. And let's move on to talk about the policy implications. For the coming month or longer, the majority of children in the US may not fully resume their daily physical activity routines due to the nationwide close of schools, gyms, recreation centers, and parks, and cancellation of sports activities. So the study was conducted in April. At that time, it was unsure to what extent the schools and facilities may reopen. And now we see the facilities are reopening, but to a limited scale. So the policy countermeasures that aim to mitigate the adverse impact of COVID-19 need to consider innovative, robust, and highly adaptable strategies to promote physical activity at home or residential settings that minimize social gathering. So I would say this study probably generates more questions than answering questions. So there are a few relevant research questions that this study inspired, and I would like to share with you. I don't have a good answer to each of the questions, but I think the questions are very relevant to policymakers and other stakeholders. The first question is, what physical activities can be performed individually or jointly by family members that have little or no restrictions on location, facility, and equipment, and how we can promote those type of physical activities. Second, how can we integrate physical activity into everyday stay-at-home routines to meet the guidelines recommended physical activity level? The third, how can we best utilize available resources at school and close surroundings to optimize physical activity? And lastly, how can we educate children and other family members about the importance of daily physical activity and ensure safety and prevent physical activity-related injury? And finally, let's move on to the conclusion. Using a microsimulation approach, this study projected the change in US kindergartners' BMI Z-score and childhood obesity under the COVID-19 induced uncertainties. Our simulation results indicate that compared to the control scenario without COVID-19, both BMI Z-scores and childhood obesity prevalence under the COVID-19 are expected to rise, and the magnitude of the increase is proportional to the length and severity of the pandemic. Therefore, public health interventions are urgently called to promote an active lifestyle and engagement in physical activity among children to mitigate the adverse impact of COVID-19 on unhealthy weight gains and childhood obesity. So that brings an end to my presentation again today. I want to apologize for not being able to monitor your questions on the run. But if you have any questions, feel free to ask, to unmute yourself or ask, or use the chat box. Thank you for your attention.
Thank you so much. That was sobering, but really helpful information. And as you said, perhaps stimulating more questions than there are readily available answers. So a few questions that emerged, but please don't feel obligated to respond if it goes beyond the scope of the study, because I think many of us are looking for what is the practice implication and what is the takeaway. So the cohort that was the basis of the microsimulation were all age mates to each other. Would you anticipate that the age of children affects the modeling? Would we expect that this would be different if a child was younger or older, or is the nature of the methodology such that the age doesn't matter if the kid's being studied and modeled?
This is a great question. The age matters because we use the CDC growth chart to simulate the change in BMI Z-scores across the age groups. So when the children become older, it will belong to a different age group, and the BMI Z-scores, the baseline BMI Z-scores would change. So here we only model the kindergartners because we have very good data, longitudinal data using the ECLSK cohort. But we can adopt this very same methodology to estimate other age cohorts as well. So the short answer is the modeling results are partially dependent on the age.
Great. And you had mentioned the importance of alternative strategies through school, robust public health policies that get kids off the couch and out into the world. I recognize that you may not have the scientific data to support recommendations yet, but I'm curious if there's anything you're seeing as a bold, creative strategy that you think is promising and deserves to be elevated as perhaps what we should be trying, even if the science isn't there yet to prove that it's impactful.
Right. I appreciate this question. It's very informative question. Well, I don't have a clear answer, and evidence is still emerging in the scientific field regarding what type of mode of physical activities are most appropriate that can, on the one hand, ensure enough exercise based on the guidelines, and on the other hand, prevent injury and other accidents. So just from my personal observation and my personal practice, I enrolled my children into some virtual summer camps that they do basketball training and motor development and soccer training online. And my children love those exercises. And at first we thought it was not possible for children to be interested in doing physical activity by him or herself online with the coach, but it proved that we were wrong. The children love the new technology, and they can follow the coach precisely and do their physical activity. Although it's suboptimal in comparison to in-person training, but I would say at least now they are able to obtain the physical activity needed based on the guidelines. But that is just my very personal observation.
Understood. So I'm not sure if you'll be able to respond to this based on your previous history studying obesity in children, but we're talking about an episode of modeled duration in a lifetime. If the episode, or if and when the episode ends and conditions return back to what they were before the pandemic, before the shutdown, before the limitations in activity, would we expect to see those obesity numbers come down, or are we concerned that 1 million children are now at risk for conditions that they weren't going to be, and that's a lifetime issue?
Right. This is another great question. So what we try to model is in comparison to the control scenario when nothing happened, there's no pandemic. What would happen if the pandemic continued for a number of months? And as we see from the modeling, when the pandemic was over and suddenly everything became normal, and then the children's obesity is going to stay at that level rather than leveled off. That is because the body weight has been accumulated to the children. And unless we do an intervention to reduce their body weight by increasing energy expenditure or by reducing energy intake, and then we won't magically believe that the children's BMI is going to reduce by themselves. This is very unfortunate. So the policy intervention is needed if we want to go back to the original BMI or original body weight status.
Okay, so very sobering numbers indeed, especially as this continues open-ended. You had mentioned that one of the strengths of the sample that you were modeling from is that it was geographically diverse, that it really addressed many, many variables. Through this study or other studies, were you able to make any determinations about differences urban versus rural or suburban? It seems that depending on where you live, your access to green space is very different.
Exactly. That's a great question, great comment. Actually, that was one of the comments from the reviewers. So in this paper, we are unable to measure geographical differences in the microsimulation, mainly because we don't have the micro data stratified by geographical locations. So basically, we don't know where those children live in the ECLSK data. But there are other microsimulation tools that you can use to make assumptions and distributionally weighting the subsamples based on the geographical locations. is called spatial microdation, a specific subdomain of microsimulation that might be able to some extent model a smaller and more specific geographical area. But just for this study, the estimate pertaining to a national average impact, and we are unable to capture the local variations in the impact.
Got it. Okay, so we have time for just this last question before summing up and wrapping up for today. It certainly suggests that, if I understood it, and I hope I did, that that the COVID pandemic has the potential to really exacerbate social determinants of health that are stacked against disadvantaged populations and do real harm to communities that are already at risk. In thinking about, okay, if this is the fact, what we might do with it, is there anything specifically through a social justice lens or a social determinants of health specific to those most vulnerable populations that you think we should be mindful of?
That's another great question. People with different demographics and with different socioeconomic status have different opportunities to engage in physical activity, and they're exposed to differential risk of childhood and adult obesity. And what we are trying as policymakers should be to focus on those who are at the elevated risk, who are most vulnerable to the lack of physical activity, to the elevated obesity risk, and try to provide more opportunities for them financially, locationally, servicely, and in many different domains that we should focus on those individuals who need the opportunities to be physically active.
Well, thank you so much for this talk and for entertaining the questions. Before we close out and wish our audience well, I just want to give you an opportunity if there's any closing comment or final takeaway that you want to leave for the audience.
Sure, I really appreciate. So I really appreciate Janet and Gary for your assistance, and for the audience, and for your patience for being with me for the last hour. And I think that to make informed decisions, we do need to provide data as the evidence, and also to use quantitative modeling tools to provide reliable estimates on what would happen if without a policy, if the pandemic continues. And the answers to those projections, to those questions, will going to be very informative to the policymakers. And microsimulation is one of the many tools that help people make an informed and evidenced decision. Whatever our decision is, I think we should based on scientific evidence rather than anecdotal evidence or data from unreliable sources.
Thank you again so much for your time, for your expertise. This is a really important issue as we look to care for our children during these extraordinary times. So thank you for your time, for your research, for your concern and care about this population and the work that you do. Please join me in thanking him for joining us today. I also want to remind you that we hope you will join us on Thursday at noon for Convocation. It will be a fantastic talk. The link for registration is in the chat. And as always, thank you, Janet, for being a wonderful co-hostess. It's great to do this with you every week, and I look forward to seeing everyone on Thursday. All right. Thank you all so much. Good night.